decades back when I started my career, it was like amongst the ENT surgeons, they used to tell tonsil is the bread and butter of the ENT surgeons. But now over the decades, we know we have to change it. And we thought that, yes, it should, like the thyroid surgeries, the thyroid should be the main domain of ENT surgeons, and it should be the bread and butter. So when it can be, when we know exactly what to do when the patient present to us. So how do we go about with that? Because solitary nodule thyroid is the common disorder which we come across in our day-to-day practice. And whenever the patient comes to you, what are the things we need to look for? Whether it's the age of the patient or the sex of the patient, of what are the swelling which the patient is present, and what exactly is the solitary nodule, the definition. And because these days we are subjecting the patients for imaging of the neck in all, like many disorders we subject them. And then we get to know there is some swelling in the thyroid. How to go about that thyroid swelling, whether it is a size which matters, and for how long we need to follow up, and how regularly we need to follow up. And if at all we feel, okay, this is crossed, it's showing a red flag, then what investigation we need to do, whether it's ultrasound neck or the blood test, and in ultrasound neck, what exactly we are looking for it. And then whenever you are suspicious, what investigation you do again, and how do you follow? And then overall, is there the molecular image, the molecular testing has any role in these patients? And how are you going to manage? In all these things, we have some, the answer, and that will be told by Dr. Ritu in her talk. And I welcome Dr. Ritu to this webinar. And Surekha has already told a brief introduction, I feel. Actually, she's got all the laurels in her basket. I wish her many more laurels in her future academic and professional life. And over to Dr. Ritu.
Thank you, Bharti Madam, for the warm welcome. It is indeed a pleasure to be a part of this for this lecture series organized by Microlabs, and thanks Microlabs for this arranging this academic session. So I shall start with my topic. Good evening, everybody. The topic we have decided today is approach to a solitary thyroid nodule. As Madam rightly said, ENT surgeons operating more thyroid glands rather than the general surgeons. Now it is a domain of the ENT surgeons to deal with the thyroid gland, and we can deal with the thyroid gland only when we are aware about it. We know about the diseases that affects the thyroid gland. So as we evolve as surgeons in this field of thyroid surgery, we progress from learning about how to operate on the thyroid gland, and then we progress to when to operate, and slowly and steadily as our years of practice increase, we change from when not to operate on the thyroid gland. Then how do we learn about the thyroid gland? The best way to learn about anything, as we have learned from MBBS days, is by mutual discussion and by attending lecture series or by demonstration or audio visual shows. So I hopefully at the end of the lecture, the retention will be more than 5% for this particular lesion. Coming to the relevant surgical anatomy of the thyroid gland, it's a simple butterfly-shaped gland lying between the carotid bodies and supplied by the external laryngeal nerve superiorly. No, not supplied. Supplied by the superior thyroid artery and the inferior thyroid artery. But there are two nerves that run in close approximation to these vascular structures. So above, when we see this lateral picture, we can see the external laryngeal nerve, the external laryngeal nerve, which is a branch of the superior laryngeal nerve, in close proximation to the superior thyroid artery. And there is this recurrent laryngeal nerve in close proximation to the inferior thyroid artery. And when we go intraoperatively, there we are in a fix, because the tumors can range from small nodules to these huge multilobular tumors. And then we have to have the delicate balance of preserving the parathyroids The superior parathyroids could be anywhere between the superior thyroid artery to the middle part of the gland, whereas the inferior parathyroid gland could be anywhere between the middle thyroid vein up till the retrosternum. And as we steer our surgical boats, we have these two thunderstorms waiting for us along the way. Either it could be in the form of a recurrent laryngeal nerve or the parathyroid glands, and they could, either of them could disrupt our boat and sink our surgical boat. And this recurrent laryngeal nerve never fails to surprise us. From this clean, nicely seen nerve on the left side of the gland, but someday the recurrent laryngeal nerve decided to go non-recurring, and there it was arising directly from the vagus and supplying the gland of the right side. So whenever we see a patient for which a thyroid swelling in the neck with moves with degradation, what are the pointers that we need to be aware of? We need to be aware whether there are any dilated veins in the neck, because that could signify a compression of the internal jugular vein. Is there any sudden change in the size of the swelling? We need to ask for the history of difficulty in swallowing and change of voice, because they could point towards the lesion becoming malignant, or whether the patient has any breathing difficulty, which could point to a retrosternal extension. Besides the routine investigation, what the other investigations we need to do? We need to know what is the condition of the thyroid, whether it is the patient is hypothyroid, whether there are features of hyperthyroidism, or is euthyroid, and what are the imaging studies we need to do? How do we decide when to do a sonography, a CT scan, or very rarely a PET scan? And do we need to do a tissue diagnosis in all the patients? I will try to touch on these topics one by one. So whenever we order for an ultrasonography of the thyroid gland, we not only want to see the ultrasonographic features of the nodule, but we could also do an elastographic study. So a sonography of the neck is ideally advised for all the patients. It helps us to see whether the nodule is solitary or there are multiple nodules in the gland, which could be missed by a clinical examination. And there could be information about the nodule, like its size, shape, position, the presence or absence of calcifications. What is the echogenicity of the nodule, the vascularity of the nodule, and whether there are lymph nodes present or not there in the central and the lateral compartment of the neck. And we could also use the sonography as a method of collecting an FNAC sample. So nowadays, whenever a sonography report is to be given for a thyroid gland nodule, then these points are taken into consideration, like the echogenicity of the nodule, the shape of the nodule, whether it is taller than wide, what is the margins of the nodule, lobulated or smooth, and what are the types of echogenic foci present, whether there are none or there are multiple punctate echogenic foci. Depending on the report, a thyroid level score is given, which could range from 0 to 7. And needless to say, the higher thyroid score points towards a suspicious nodule, and we need to be aware about it. To study to be and this elastic will be blue in color, whereas a solid component on the nodule will change the pattern more to greenish in color. And do we do a thyroid scan in all the patients? So, and does it rule out cancer? So earlier when we started our residency, we were doing a thyroid scan for all the patients, to see whether the nodule was warm, hot, or cold. But nowadays, it does not actually, a warm or a hot nodule does not rule out cancer. There could be some small malignant nodules somewhere. So nowadays, it is not routinely done unless the patient has Graves' disease. So do we do a CT scan in all the patients, or do we keep them reserved for certain category of patients? A CT scan is usually not advisable for all the patients. It is usually done only when we suspect a retrosternal extension or some sinister complications like a tracheal or esophageal compression. Earlier, CT scan was contraindicated because it was felt that if a radioactive iodine has to be given post-operatively, then a CT scan contrast dye which is to be given would interfere with that. But nowadays it is not so. Now it has been proved that if we give a water-based iodine contrast, there is a sufficient 1 month time available for the urinary iodine to return to normal. Therefore, whenever we suspect extension into the trachea or the esophagus, it is better to do a CT scan with a water-based iodine contrast medium. So do we order a tissue diagnosis like an FNAC in all the patients? Because the thyroid gland is highly vascular. Do we do it or we don't do it? So whenever we have a sonographic features which point towards a pure cystic nodule, then FNAC could be avoided. However, but if we feel suspicious features are present in the nodule, there is a solid with cystic component, then for better localization of the needle, it is always better to do a sonography guided fine needle aspiration cytometry. So in the solitary nodule, the sensitivity of picking up a cancer could range up to 80%. In the best of hands, it could go up to 90%. So all hypoechoic nodules above a centimeter in size, which are posteriorly placed, and the presence of calcification would be an indication for doing an FNAC. And all the nodules with extrathyroidal extension, or there is extrusion through the rim, or abnormal cervical lymph nodes, we would definitely order an FNAC of the nodule. So when we have the histology report coming to us, depending on from where the nodule has arisen, whether it is in the follicular epithelial cells of the thyroid gland or the parafollicular cells, the histopathology could range from the differentiated thyroid cancer to a medullary cancer. We shall just study briefly about them one by one. So in differentiated thyroid cancer, the FNAC report is usually given in the form of a Bethesda grading. Depending on the nuclear characteristics, the types of cells present, the Bethesda grading is given from 1 to 6. Needless to say, a Bethesda grading 1 and 2 would usually point towards a benign disease, and 5 and 6 would be more in for malignancy. There comes a category of Bethesda category 3 and 4, where we are just taken aback and we don't know what exactly to offer to the patient, whether we repeat the FNA or that we take the patient for a surgical lobectomy. So a new terminology has been added, which is a non-invasive follicular thyroid laser with nuclear features. If these features are present, if an NIFTP diagnosis has been given to the patient, then the malignancy risk can almost become half. So if those features are present and if the pathologist is expert enough to report it, then we can avoid the surgery in many of the patients. So these are a few characteristics that the pathologist studies: the cellular pattern, the presence of Samoa bodies, and the presence of mitosis to decide whether we give a diagnosis of NIFTP or not. And then there are certain molecular factors like the presence of BRAF gene, the RAS gene would also help us decide. Now, why do we need to know? We can no longer be not aware about these things, because it is seen that whenever there is an indeterminate thyroid FNAC, the main dilemma that we face is whether to operate or not to operate. We need to be aware that there are molecular marker studies available, if not so commonly in India, but definitely abroad. There could be two types of molecular studies, which could be a rule-out test or a rule-in test. A rule-out test, like an AFOMA test, could indicate a benign disease, and we can avoid diagnostic surgery in these patients. And a rule-in test which confirms malignancy is the study of a thyroid-specific gene pattern. It is these drawback. The main drawback of these studies are they are very expensive. The cost may go up to 2 lakh rupees, and it is not commonly available till now. After we have seen the nodule and we have the sonographic features in mind, we need to know what is the size of the nodule. The size of the nodule, and there is a classification from T1 to T4 depending on the size. So T1A tumors are less than centimeter, whereas T4 tumors will be tumors which engulf the vascular structures of the neck. There's a new modification in the staging of the thyroid tumors. Earlier, the cutoff age was 45 years, and we used to follow ages, AMES, and the Lahey's method to stratify the risk of a patient. But nowadays, it is always preferable if we use the TNM staging. And in the 8th edition, the modification has been made. If you see carefully, any tumor size which is in a patient less than 55 years of age with any lymph node metastasis, all fall in the stage 1 and 2 or the low risk group. Whereas all patients above 55 years of age, in spite of it, they having little bit extrathyroidal extension, still fall in the stage 2. And stage 3 is used for only gross extrathyroidal extension. This has been a major change from the previous 7th edition ADCC classification. So this table just clarifies how all the tumors of the thyroid gland have got downstage to stage 1 and 2. Now 3 and 4 are hardly any tumors will be there, which will be very large, engulfing the esophagus, larynx, and trachea. And these stage 1 and 2 tumors are what we commonly see in our country. So once we have studied the thyroid gland, seen the sonographic features, decided upon the type of the histology present in the patient, how do we decide whether to do a hemithyroidectomy or a total thyroidectomy? A hemithyroidectomy usually remove only one side of the lobe along with the isthmus. So usually solitary thyroid nodules, which fall in the Bethesda category 1 and 2, the low risk cancer group, and patients less than 55 years of age do very well with a hemithyroidectomy only. Only the patients who fall in the high risk group with gross extrathyroidal extension to the surrounding structures and the presence of lymph nodes would go in for a total thyroidectomy. So the trend has been more towards the conservative surgery in thyroid patients, because it is seen that the patient of thyroid cancer in the low risk group never dies of a cancer of the thyroid. They die of other morbidities. So when we have to do a total, do we do subtotal or we do total? So there are pros and cons to both of them. The main problem with doing a subtotal thyroidectomy is that in case the histopathology is reported as cancer, then going in to remove the sliver of thyroid tissue would make it extremely dangerous for the recurrent laryngeal nerve. It is, if we have decided the patient is in the high risk group, it is better to go in for a total thyroidectomy, because in expert hands the risk for recurrent laryngeal nerve is hardly there, and a lifelong supplementation of drugs may be given for even subtotal. So why not do a total instead? Coming to the lymphatic drainage of the thyroid gland, usually the drainage is bilateral. There are a lot of lymph nodes. There could be pre-laryngeal lymph nodes, pre-tracheal lymph nodes, paratracheal lymph nodes, mediastinal lymph nodes. And the lymphatic channels are usually parallel to the nerves. But it is seen, and a high risk of nodal metastasis may also be seen. However, the nodal stage disease does not upstage a tumor. As we see, N1 disease is no longer upstages the tumor if the patient is less than 55 years of age, and even if he has a lymph node positive, he still falls in the category of stage 1. And previously considered level 7 lymph nodes, which were the mediastinal lymph nodes, are now coming in the category of the level 6 lymph nodes. So there is a debate regarding a prophylactic unilateral or bilateral leg dissection to be done, and it is seen that there is a very little impact on outcome. Unlike the carcinoma of the buccal mucosa, there is very little impact of nodal metastasis in a thyroid cancer patient. And then we have this category which is most commonly seen. We have FNAC reported as benign. We do the hemithyroidectomy, and then the final report shows us well-differentiated thyroid cancer. Then many a times the ENT surgeons are taken back. Now what to do? Whether we do the completion thyroidectomy, we don't do the completion thyroidectomy. There is no need to panic. We just stratify the risk of the patient and classify him into the low risk or high risk, and then decide whether to observe the patient or to go in for a total thyroidectomy. So the risk stratification would be a low risk patient would be a patient with an intrathyroidal differentiated thyroid cancer with less than 5 nodes positive and a T1 and T2 disease. Mind you, a T1 and T2 disease could range up to 4 cm, but they still fall in the low risk category. Whereas the high risk category would be gross extrathyroidal extension and incomplete resection at presence of distant metastasis, or a T3, T4 tumor, and all metastatic tumors would fall in the high risk group. There's a huge group, which is the intermediate group, which has an aggressive histology, and more than 5 lymph nodes may be positive, but they are all micrometastasis and maximally ranging up to 3 cm. These patients could be put in the intermediate risk category. A radioactive iodine could be done for these patients. So do we do a radioactive iodine therapy for all the patients whom we do a thyroidectomy? First of all, we need to know that in patients whom we have done a hemithyroidectomy, do not go in for an adjuvant radioactive iodine therapy. Radioactive iodine therapy is done for only those patients who have undergone a total thyroidectomy. So according to the latest recommendation, REI remnant ablation is not recommended for any low-risk DTC patient. It is recommended only for high-risk DTC patients. So we need to go back to the AJCC classification, decide where the patient lies, what is his risk factor, and then decide about the adjuvant radioactive iodine treatment. Usually, if the patient has undergone a total thyroidectomy, then at the end of 4 weeks of stopping eltroxin, a radioactive iodine diagnostic scan is done with 3 to 5 millicuries, and depending on the uptake, a 30 to 50 millicurie dose is given through the thyroid gland for thyroid gland ablation or any lymph nodes in the paratracheal region. So now, how do we manage the parathyroids in any thyroid surgery? needless to say, we need to preserve all the parathyroid glands as far as possible. Even when we are doing hemithyroidectomy, they are best identified and preserved, just in case if we have to go in for a completion thyroidectomy. So we not only preserve the glands, we see that they are not discolored at the end of the surgery. We should try to maintain the vascularity of the gland by dissecting, having a subcapsular dissection in the posterior part of the thyroid gland while dissecting. And if there is an injury to the parathyroid gland, then it's better to pick it up faster and estimate the serum calcium in the post-operative setting. Some patients may require to be given an active form of vitamin D3 for a few days. And what do we do when you have a tumor on the recurrent laryngeal nerve? So it is seen that a functioning recurrent laryngeal nerve should never be sacrificed. A non-functioning nerve could also recover post-operatively. The only reason why a recurrent laryngeal nerve should be sacrificed if we see that we have removed the tumor everywhere. The only place where it leaves behind would be a recurrent laryngeal nerve. Only in that case we would consider cutting the recurrent laryngeal nerve. Otherwise, no. And if possible, if there was a necessary or a need to cut a recurrent laryngeal nerve, it's better to do anastomosis with ansa cervicalis in the same setting. And this is one complication where everybody has faced once in a while in their thyroid journey. So there's nothing to get worried about it. We need to know whether it's a unilateral or a bilateral recurrent nerve paralysis. So usually in a unilateral recurrent nerve palsy, there is no every compromise. The recovery is seen within 6 months. The compensation is good. Very rarely, a vocal cord medialization procedures may need to be done in the form of fat infiltration. Just in case you have done a total thyroidectomy and you have a bilateral recurrent nerve paralysis, then the paresis is more problematic than the palsy because the abductor fibers are present peripherally, and usually if they get affected, then the patient could go into stridor and may require a tracheostomy. And in this case, if they do not recover, then a vocal cord lateralization procedure can be done at the end of 6 months. Or very rarely, laryngeal re-innervation surgery could be tried for these patients. So this complication is best avoided by the use of intraoperative nerve monitors. But unfortunately, the cost of this procedure is high. It is a great tool, especially in revision surgeries, but it is not available in all setups, and there is a steep learning curve to this. We cannot miss out on the incidentallomas, which nowadays we see the patient is getting screened for an executive health check and a nodule has been detected in the thyroid. So no need to panic. We go back, stratify the disease, do the required investigation and carry out a treatment. And sometimes we have removed the thyroglossus cyst in an adult patient and histopathology shows up as papillary cancer with thyroid. So we just stratify whether the patient is in a low risk group. Usually these cells have negative margins, there is no cyst wall invasion, and the thyroid gland is normal. There are very, very few patients who may fall in the high risk category. They may have larger tumors and there may be a tumor associated in the thyroid gland. In these patients, they may have to undergo a total thyroidectomy because we need to give a radioactive iodine treatment for these patients. The discussion about the thyroid cancer would be incomplete without discussing medullary cancer of the thyroid. Usually, we need to know that in medullary cancer of the thyroid, the surgery is the only means of cure. We do not have a radioactive iodine available for us for medullary cancer of the thyroid as the tumor arises in the parafollicular cells. And all patients with MTC should undergo genetic counseling and a DNA analysis. They should do a baseline serum calcitonin and a serum CEA levels. So usually with the level of the calcitonin, we get a fair idea whether the presence of metastasis is there or not. If the serum calcitonin levels are less than 20, then there are no lymph node metastasis. And if it is 20 to 50, there could be ipsilateral, central, and lateral lymph nodes. However, if the serum calcitonin levels are more than 500, then there is definitely going to be an upper mediastinal lymph nodes and distal metastasis. A serum CEA levels in the same way. If we have more than 100, then definitely the patient has distal metastasis in 75% of the patients. So all patients with medullary thyroid cancer have to undergo a total thyroidectomy, either with a central limb dissection along with a lateral limb dissection, depending on what is the serum calcitonin levels and the sonography report. So, it's always better to do RAD mutation gene analysis for all the patients. just in case, post-surgery, when we have calcitonin and CEA measurements for these patients, if the serum calcitonin has less than 2 picogram per ml, we know that we have done a complete surgery, and we just need to repeat these tests after 6 to 12 months of follow-up. However, if the serum calcitonin level is elevated post-operatively, then that could signify a presence of residual disease either in the neck or in the other structures and a distant metastasis to it. God forbid if anybody of us faces this patient, it's an anaplastic thyroid cancer, we can lose this patient within few days from diagnosis till to respiratory compromise. A very fast, rapidly growing thyroid tumor. Sometimes we don't even have time to start external beam radiotherapy for these patients. So in the future, the thyroid cancer is definitely on the rise worldwide. We need to be aware how to manage these tumors. They are pretty much curable if detected at an earlier stage. And it is the molecular markers or the gene sequencing is going to be the future, and it will not be far when the patients would ask for these tests before undergoing a lobectomy, especially in Bethesda category 3 and 4. So as we grow as surgeons, a good judgment we learn from experience as well as from having adequate knowledge, and experience definitely comes from that judgment. As we need to treat the disease as well as treat the patient who has the disease. Thank you. And now we would be open for question and answers.
Thank you, Dr. Ritu. It was a panoramic view of the entire thyroid nodule and the other common diseases which we see you have covered so well. And some questions are there. Dr. Jaiprakash Reddy has said, very good explanation. Congratulations, madam. And Dr. Amulya, I would like to know about the follow-up of TIRADS 2 and 3.
So TIRADS 2 and 3 would be, TIRADS 2 would usually point towards a benign disease. And if you have decided not to do the FNAC as a cystic nodule, you could follow up these patients every 6 months with a serial sonography if the patient does not want to undergo. And it one of the reasons for doing surgery in a benign thyroid disease would be cosmetic reasons. But however, if the patient is fine with it, then we can observe these patients and follow up every 6 months with serial estimation of TSH and sonography.
And TIRADS 3, I think you already told. Will you just repeat for the benefit?
Yeah, TIRADS 3 would be more having a few of the suspicious features, and then we would be more aggressive of the follow-up if the patient is not willing for the surgery. And FNAC would also help us guide the Bethesda classification for the FNAC, would also help us to find out from what type of nodule the patient is having. So if both the features are suspicious, then it is better to offer surgery to these patients.
I wanted to know about your experience with airway management in anaplastic CA.
Anaplastic CA anaplastic CA causes a very fast invasion into the trachea, I think. And usually we don't operate on these patients. We don't have that much time for these patients. So 2 times I have seen these patients. One patient, we tried to do a tracheostomy. We could not achieve because the thyroid gland was right in the way. So the patient was kept intubated. And then with the tube, the patient was being taken for radiotherapy, but he did not survive that.
Yeah, it carries very bad prognosis. Only thing is the other alternative, as you said, is we can intubate the patient, give the airway and give the external radiation, and it melts actually. But they have the very bad prognosis. And Dr. Sharma...
in one patient, the chest physician had tried a tracheal stenting also, but it's for some airway, but not very successful.
Dr. Sharma, nodule size 3 centimeter, all other low risk features, BRAF positive, hemi or total thyroidectomy to be done.
At the age of the patient?
Low risk. That means less than 55 years, maybe so female,
they would
but only BRAF positive is there, and size is 3, that's also less. Hemi or total?
I would prefer to do a hemithyroidectomy for this patient because if BRAF is positive, that points towards malignancy, but still it is a low risk group. So then we have to save the other part of the thyroid. No need to knock off the total thyroid of the patient.
Do this like, whenever we do any of these sort of, observation or hemithyroidectomy or in conservation laryngeal surgery, we take a point about the patient factor, like the patient follow-up should be better, like they should be in reach. Do you take this point in the thyroid malignancies also?
Usually I've seen the patients who have developed thyroid cancers are usually from a good economic strata. So they have a good follow-up. Very rarely do we see, usually in all these villagers and all these type of people who have a bad follow-up have benign, large thyroid goiters, but they're usually benign. And the cancer is mainly seen in patients, usually they will follow up, I think. Once they have the diagnosis of cancer, they are after us to do a total thyroid actually.
Yeah. Dr. Munka has, thank you, Dr. Munka, for attending. He has all the, excellent, crisp presentation, covered most of the points. Congratulations, Dr. Ritu. And Dr. Gangadhar, nice presentation. I think nice presentation, superb, Dr. Palanip, and all appreciation. So your talk was so, good and everything was there. So lots of appreciations we have.
Madam, would you like to add something to it depending on your experience on this?
The same, only thing is these days actually, as you said, we'll just discuss how exactly you go about when the patient comes to you with solitary nodule thyroid, like what investigations you do.
So as I said, I usually do first I need to know the thyroid profile, whether the patient is euthyroid, hypo or hyper. Because nowadays I've seen thyroid cancers in euthyroid, in hyperthyroid, in hypothyroid, all type of patients. So preparing them for surgery, I need to have a euthyroid status. So that is one thing. And just having a hypo or hyper does not rule out cancer in any way. And secondly, I asked for a USG of the thyroid and a USG guided FNAC of the thyroid gland.
Yeah. Yeah, that's what everyone has to just make it a point to add. The first investigation will be TSH and ultrasound neck, that's all. And then if needed, then ultrasound guided FNAC. So all ENTs, the surgeons have to make it a point to get ultrasound guided FNAC if needed. Yeah. And then when we decide, as you said, the ultrasound grading we do, then whatever the FNAC, everything, and then you make it then you diagnose it as whatever the diagnosis comes, either malignancy or non-malignant, benign, and then risk stratification, we need to do it. That is very important because many of us, I've seen many, they do surgery, but the risk stratification they don't give. So that should be there for all ENT surgeons, should follow that. Yeah, adenic oncologist, that's different, but because this is a ENT platform, so I want to emphasize that risk stratification has to be done. Then only your follow-up is very good and you know what to do with your patient. And then, as Ritu rightly put forward, it's either hemi or total. There's nothing in between. So hemi is lobectomy with isthmectomy. And then you have the total thyroidectomy. And what are the indications she neatly put forward? And then, and if at all, what is the indication for completion thyroidectomy also, she said. And what problems we come across whenever we are doing thyroid surgeries. So that also she said, RLN, then parathyroids. See, nowadays we are not so much bothered about the nerves. We know where are the nerves. We are not going to injure the nerves. We are especially the ENT surgeons are fully on that. Only point comes is with the parathyroids. And as she said, it is not the vascular supply, it is a drainage. That is the venous drainage also, we need to take care of it. because in the immediate post-op, if at all the venous drainage is affected, there will be suffusion in the gland and then it might not function. So that we should take care of the venous drainage of the parathyroids also, and how to look for parathyroids also she has put forward. And then another thing I wanted to tell something about the parathyroids over the, yeah. And recurrent laryngeal, now, if at all you injure, if at all, actually we have seen if the thyroid gland malignancy is very big, the recurrent laryngeal now is only because of the pressure effect, the paralysis is there. So you can say that now. But if a small thyroid gland is there, which is malignant on FNAC, and then the patient has got the recurrent laryngionopathy, it is usually adherent or the infiltration into the now, that we have seen. Of late, I think last 3 cases, we have seen a small gland, and then when you open the recurrent laryngeal now is adherent and it is going through the tumor. So we had to sacrifice, and on the same time, you do the ansa cervicalis anastomosis. That actually maintains the volume of the vocal cord. Then you can give the exercises if needed, even the thyroplasty type 1 later you can go ahead. And then another point is recurrent laryngeal now is okay. And the airway management, as Dr. Amulya put forward. Okay, one more question is there. Some patients do have features of both papillary and follicular in same node. How to proceed? Do you take it as papillary or do you take it as follicular?
Yeah, so in that now all are considered as well differentiated thyroid cancer, because now no longer the ages, invasive, capillary, follicular, all that we don't consider. We just need to know whether it is invasive or it is not invasive. Definitely follicular, there is a high risk of metastasis and distant metastasis. But however, the patient falls in the low risk category, then there is no problem with managing the patient. They are managed in the same way.
So you mean you take it into consideration as follicular variant of papillary or follicular carcinoma?
Yes. Yes.
And now another question is how to manage hypocalcemia post-surgery?
Yeah, so hypocalcemia we usually see in a patient whom we have done a total thyroidectomy or we have done a completion thyroidectomy, and the parathyroids were injured pre-operatively, by earlier surgery. So now in this patient, we need to measure the serum calcium every day. That means I start monitoring from day 1 itself, next day onwards. So usually the parathyroid, the serum calcium deficiency sets in after 24 hours. It starts and it peaks at 48 hours. So if you do a serial estimation, so usually the calcium is between 8 to 12. So if the first day the calcium is falling on around 7.5 or so, you know that the patient is going to develop a more calcium deficiency after 48 hours. So in that case, it is better to start the patient on a calcium drip. Or you could do a vitamin D3 supplementation in the form of 125 dihydroxy cholecalciferol tablets are available, like Rocatrol. So they can be given 1 tablet 3 times a day with oral calcium. And then when you estimate at 48 hours and you feel the calcium wall has fallen down, then we need to give IV supplementation of calcium. So I usually prefer 1 ampule in 100 ml of normal saline to give it slowly over 1 hour. That is the safest method, because sometimes the residents or we ourselves are not there available to give the calcium drip with pulse monitoring. So this type, when we give it slowly over 1 hour, then the calcium is taken care of. The drip can be repeated up to 3 times a day, depending on the calcium levels. And usually it is seen after 48 hours, the parathyroids start recovering. Needless to say that we should be aware that whether we have identified the parathyroids, were they devascularized, or we have not been able to identify the parathyroids. So that is very important. If we know that we have definitely injured the parathyroids, then patient will require long-term supplementation of calcium. But however, if there is only a slight vascular compromise, they start recovering after 48 hours.
If by, inadvertently we remove the parathyroids and you think it is parathyroid, how do you go about it?
So I implant it in the sternomastoid muscle. in the same sitting. Make a small tunnel and put the parathyroid gland, but that would take some time to recover. So the patient may develop hypocalcemia postoperatively.
Do you prefer the sternocleidomastoid muscle or the forearm muscles in malignancy? It's any diversity is there, or in all cases you do sternocleidomastoid
No, I
muscle?
prefer sternocleidomastoid muscle because it's locally available.
Okay. And one more question. Why ultrasound guided FNAC?
So what happens is sometimes we have mixed nodules. We have a solid and a cystic component to the nodule. So when the pathologist blindly does the FNAC without a sonographic guidance, then he may just remove the cyst fluid, and then our diagnosis may not be accurate. But however, if we have a sonographic guided FNAC, then we can target towards a solid component in the cystic nodule to get a more accurate diagnosis of cancer if it is present.
Yeah.
And plus we can avoid the vascular vessels also, because when you have sonographic guidance, then because thyroid is highly vascular, sometimes the needle may go through a blood vessel, there could be bleeding and sudden increase in the size of the nodule, which could be easily avoided with sonography.
So these are the 2 points which we take into consideration. One is from the solid component, we get the cells so that the pathologist can identify and give the report, and then we can avoid the vascular injuries. And another question, can we shave the tumor off the nerves in differentiated thyroid cancers so that post-operative reactive iodine will take care of microscopic disease?
So what happens is that in that case, we should be sure that we have not left the tumor anywhere else. Because what happens in the post-operative setting is that the patient is off the thyroid hormone. So it is a TSH sensitive tumor, the well-differentiated thyroid cancer. So in the 1 month waiting period for the TSH to go up to make it sensitive for thyroid radioactive iodine, there could be enlargement in the tumor size. So you can shave off, but if it is that only, if you feel that you can get away with removing complete tumor, an R0 resection is always preferred to an R1 resection, even if microscopic disease is there.
Yeah. Maybe if the patient has already got paralysis, I think you can remove. Or if the patient doesn't, it's a functioning nerve, and maybe you can. But as far as possible, R0 resection is important.
Required, yeah.
Then does the statement at least one parathyroid with vascular supply and venous drainage to be preserved holds good?
Yes, it does.
Yeah.
It's always preferable to save all 4, but definitely one we need to save, especially when you have a parathyroid, hypoparathyroidism, and we need to remove the parathyroid gland. So at least one we need to save.
Yeah. As far as possible, preserve all the 4 parathyroids, or if not, at least one, because whenever we are doing the central compartment dissections, so your inferior parathyroids are jeopardized because the vascularity you are taking off. So at least superior parathyroids you need to preserve properly, and inferior parathyroids, even if the vascularity is not there, they should be preserved. Could you share your experience with long-term recurrent hypercalcemia post-thyroidectomy, and how do you manage such cases, Dr. Amulya here?
So as far as long-term I make it a point to preserve the parathyroids for all the patients. So I have not faced this long-term parathyroid deficiency for any patient. I've seen that most of them, they recover after 48 hours. There was only once when we had anaplastic CA thyroid, we removed the thyroid gland suspecting well differentiated, but it turned out to be anaplastic. That patient developed long-term parathyroid deficiency. So we were giving IV calcium, then the histopath came as anaplastic, and then we could not do much for the patient anyway. Madam, what about your experience on that?
Actually, in the initial phase of my career, I had long-term hypercalcemia. But of late, as you said, when the experience goes on, you know how to preserve the parathyroids, and your skills will improve. And then that is the answer you get. You will not have hypocalcemia. Maybe the transient hypocalcemia will be there.
Yes, definitely.
Yeah. And especially even the transient also is less these days. But in individuals who are obese, I observed this transient hypocalcemia more in them. In the, I don't know what is the thing. Obese individuals I've seen.
And plus, in our country, many ladies are having vitamin D deficiency preoperatively itself. So in those patients, it precipitates more.
Correct.
And if they have normal, it's always better to nowadays. I started doing vitamin D levels preoperative also, so that I can start in the waiting period. I can give vitamin D supplement to these patients. Then post-op is much smoother.
Yeah,
it's worth doing a vitamin D level preoperatively, not only serum calcium.
So that's a well taken point. Dr. Anand has asked, Madam, what is the prognosis or effectiveness of nerve muscle pedicle innervation in unilateral abductor palsy?
I have not done. I don't have any idea, Madam.
No. Usually we go for other surgeries. Now to now, anastomosis, not the nerve muscle pedicle. Then we had an extensive case of parathyroidomatosis, unresectable in view of encasement of subclavian vessel. What can be done further?
But what is histology? I didn't understand the histology.
Parathyroidomatosis.
I think I should read it up.
Maybe, I don't know. Parathyroid tumor, maybe, I don't know. Unresectable in view of encasement of subclavian vessel.
It's basically inoperable tumor. I don't think we'll be able to do much about this patient.
Dr. Amulya here again. Any tips for budding surgeons? Mistakes to be avoided at the beginning of your career?
I think you need to identify the structures and preserve them. So when you're taking the superior thyroid pedicles, look out for the external laryngeal nerve, because even hypothyroid paresis could give to voice problems. You need to identify the structures and save them rather than just blindly ligating the structures. And secondly, as far as parathyroids are concerned, earlier we were, as residents, we were taught to ligate the inferior thyroid artery away from the thyroid gland. But nowadays we are not doing that. We're trying to each individual branch of the inferior thyroid artery supplying the thyroid gland and not blindly ligating the inferior thyroid artery. And trying to identify each and every parathyroid before taking out the thyroid gland. A subcapsular dissection on the posterior surface of the thyroid to drop the parathyroids, so that even the vascularity is not compromised. This is a very good way of preserving the vascularity of the parathyroid glands. And sometimes I prefer to do a superior to inferior dissection, so that I can save the superior parathyroid gland, lift the thyroid superior part of the thyroid gland away, and inferiorly I just told you that I ligate individual branches of the inferior thyroid artery. It takes some time, but then it is worth doing that effort to save the parathyroids.
I think we have covered all the questions, exhaustive questions for you. And it was a nice session. I thank everyone who was present for this Saturday evening thyroid nodule update. And I thank Dr. Ritu for sparing your time. I thank all the delegates over here and who spared their Saturday and spent with us.